Hello, my name's Kristen Mahoney, and Kara McKee and I will be presenting syndrome of inappropriate antidiuretic hormone and diabetes insipidus, better known as SIADH and DI. So, syndrome of inappropriate antidiuretic hormone, or SIADH, is defined as a grouping of symptoms that results from secretion of ADH. So it's like a too much secretion of ADH. ADH is a hormone that's released from the posterior pituitary gland, and when there's too much of it, it results in severe water retention, despite low serum osmolality. And it's important to note that ADH secretion is independent of volume, but is dependent on stimulation and osmolality.
For the pathophysiology, SIADH is caused by the inability to suppress the secretion of antidiuretic hormone, or ADH. ADH is released from the posterior pituitary, and SIADH ensues as a result of the various etiologies discussed in the next slides. This results in a concentrated urine, which also reduces urine volume. Then, this leads to water retention, subsequently increasing total body water. The increase in total body water expands the extracellular fluid volume, causing increased urinary sodium excretion. As a result, this further lowers the plasma sodium concentration. The etiology includes central nervous system disorders, including brain tumors, hemorrhages and hematomas, traumatic brain injury, infections, Guillain-Barré syndrome, and systemic lupus erythematosus, chronic lung diseases, including COPD, infections such as bacterial, viral, TB, and aspergillosis, bronchiectasis, and positive pressure ventilation. Malignancies, including carcinomas, sarcomas, leukemia, malignant lymphoma, and mesothelioma. Pharmacological agents that increase ADH production or potentiate ADH action include, but are not limited to, hormone administration with vasopressin, desmopressin, or oxytocin use, antidepressants, NSAIDs, Tegretol, morphine, cyclophosphamide, amiodarone, vincristine, nicotine, alcohol, linezolid, and Amaryl. Heredity, such as a mutation of the renal V2 receptor, and other conditions including AIDS, physiologic stress, pain, and general anesthesia. So for the risk factors for SIADH, you will see a lot of overlap with the etiology. Risk factors include greater than 50 years of age, pulmonary conditions, nursing home residence, which can be caused by central nervous system disease, higher daily rates of medication use, or low sodium tube feeding. Post-operative states, which are often associated with a hypersecretion of ADH. You may also see it as a complication of transsphenoidal pituitary surgery and cardiac catheterization. Malignancies, medications, central nervous system disorders, endurance exercise, and genetics. The subjective findings of SIADH include the patient could be asymptomatic, especially if the hyponatremia is chronic. The serum sodium could be below 120, and the patient may not have clinical manifestations. Headache, weight gain and edema, nausea, vomiting, and abdominal cramping, malaise or generalized fatigue, muscle cramps and gait disturbances, and memory and cognitive issues. Usually, the earliest manifestations occur when the serum sodium concentration falls below 135. Objective findings include hypothermia, hyponatremia, concentrated urine with a urine sodium greater than 40, decreased urinary output, decreased deep tendon reflexes, focal findings, seizure, somnolence, lethargy, obtundation, and coma, respiratory failure, encephalopathy, and cerebral edema. The specific lab criteria for SIADH will be discussed in the next slide. For labs and diagnostics, the Schwartz and Barter criterion includes serum sodium less than 135, serum osmolality less than 275, urine sodium greater than 40, and urine osmolality greater than 100. There should be an absence of volume depletion, such as normal skin turgor and blood pressure within normal range. Patients are typically euvolemic with SIADH. Absence of other causes of hyponatremia, including adrenal insufficiency, hypothyroidism, cardiac failure, pituitary insufficiency, renal disease with salt wasting, hepatic disease, and drugs that impair renal water excretion. Also, there should be correction of hyponatremia by fluid resuscitation. Other labs and diagnostics include a renal function test. The BUN may be less than 10 or normal in the absence of dehydration. The ACTH is normal. Morning cortisol is normal. The urine specific gravity is greater than 1.02. A thyroid profile should be collected to assess for hypothyroidism. A fasting lipid profile, liver function tests, because hyponatremia is often associated with liver cirrhosis. A CT of the head, nasal sinuses, and chest. A CT of the head could assess for tumors, encephalopathy, and evaluate for cerebral edema. A chest CT can assess for small cell carcinoma, which is often associated with SIADH.
Next, we're going to get into the pharmacological evidence-based practice of SIADH. So, a lot of times your treatment is going to be guided based on the severity of symptoms. So let's say you have a patient come in and they're comatose, unresponsive, seizing, and you're suspecting SIADH or, hyponatremia, then you can give hypertonic saline, 3% hypertonic saline. You can give 150 cc's over 15 minutes, and then if symptoms don't improve, you can repeat the dose after 20 minutes. And then you're going to monitor the serum sodium 6 hours, 12 hours, 24 hours, and 48 hours after infusion. The goal is to raise the serum sodium by 1% an hour until you reach 130 MEQs. But it's important to note that you don't want to raise the serum sodium more than 10 to 12 MEQs in a day. If your patient has milder symptoms and their serum sodium is greater than 120, then you can use salt tablets. 1 gram of salt is equivalent to 35 cc's of the 3% hypertonic saline, which I thought was kind of interesting. And then a lot of times you'll see a loop diuretic used as well, and that is thought to increase urine output and reduce water retention. And then you will also see DDAVP and hypertonic saline used. But in the literature, I found that if the patient isn't adequately fluid restricted, then sometimes the DDAVP isn't super effective. For hospitalized patients, you will see vasopressin receptor antagonists that can be used. They're rare with patients who have a serum sodium less than 125 MEQs, and they can cause rapid correction. So these drugs, Conivaptan, the initial loading dose is 20 milligrams over 30 minutes, and then it's usually recommended to follow that up with a continuous infusion of 20 to 40 milligrams a day for 1 to 3 days. And then you have tolvaptan. The dose is 15 milligrams PO daily, and you can increase the dose by 15 milligrams until you reach 60 milligrams per day. And then when you give those medications, especially the one through the IV, then you want to monitor serum sodium levels every 2 to 4 hours. In chronic or asymptomatic patients, you can see urea 0.25 to 0.5 grams per kg per day. Urea is used for refractory fluid restriction hyponatremia, and NS can also be given to those with sodium levels less than 120. And plus Lasix, and the sodium should only increase by 0.5 MEQs per liter per hour. And then you also have the demiclocycline, which is the dose is 300 to 600 milligrams PO BID, and that drug, it can increase the risk for renal failure in patients with cirrhosis. So that is important to note. Next, we have the non-pharmacological evidence-based practice of SIADH. So you want, excuse me, you want your patient to be fluid restricted, so you only want them to receive up to 1 liter a day. And in chronic SIADH, you want to initiate seizure precautions. You want their fluid restriction to actually be 500 cc's less than their daily output. So let's say they urinated 1.5 liters. You would want their fluid consumption to only be 1 liter. And then in medical emergencies, they'll use extracorporeal procedures. So some of these medical emergencies include seizures, cerebral edema, cerebral hemorrhage, pulmonary edema, and respiratory arrest. And that's typically seen in most cardiac patients who are hypervolemic or hyponatremic. And some of the procedures include venous-to-venous hemofiltration and low efficiency daily dialysis. Okay, next we have interprofessional collaboration for patients with SIADH. So some of the team members that you might see, endocrine could potentially be on board. The hyponatremia associated with SIADH, it can sometimes be caused by adrenal dysfunction or thyroid dysfunction. And then also ADH is a hormone, so a lot of times you'll see endocrine on board. You could also potentially see neurology or neurosurgery on board because the hyponatremia associated with SIADH can cause an increase in ICP. So, if that happens, sometimes neurosurgery needs to come check the patient out. And then sometimes SIADH can be seen following pituitary surgery. So in those cases, neurosurgery is probably already following their patient. And then sometimes you can see renal dysfunction in these patients, and you may also see increased sodium in the urine, so nephrology could potentially be a consult. And then obviously pharmacist, nursing, PTOT, dietitian, anyone else really can make up the management team. So lastly, for SIADH, we have geriatric considerations. So these patients, ADH levels are increased for any given plasma osmolality level, which would indicate a failure of the normal response of the kidney to ADH, which makes the patient susceptible to water changes. And some physiological changes that take place that make the patient susceptible are decreased renal mass, decreased cortical blood flow, decreased sodium responsiveness, and decrease in GFR. And then additionally, the sensation of thirst, renal function, concentrating abilities, and hormonal modulators of salt and water balance are also often impaired in the elderly, which can have an effect on electrolytes and cause electrolyte abnormalities. And then ADH release is actually not impaired with aging. But as a result of all these problems and physiological changes, it creates more differentials to have to weed through. And then the electrolyte abnormalities can predispose a patient to falling. So sometimes they'll have more falls at home. So next we have diabetes insipidus and some disease background and the definition of diabetes insipidus. So it's a polyuric syndrome from deficiency in ADH. So we went from hypersecretion of ADH to too little ADH, which causes volume depletion and concentrated urine. There's 3 types of diabetes insipidus. You have central, which is a deficiency of ADH production or release. You have nephrogenic, which is renal insensitivity to ADH. And then you also have psychogenic.
For the pathophysiology of central DI, it involves inadequate or impaired secretion of ADH from the posterior pituitary gland in response to osmotic stimulation and a decrease in blood pressure. Neurohypophysis consists of a complete neuronal unit responsible for synthesizing and secreting ADH. These units include the hypothalamic cell bodies in the supraoptic and paraventricular nuclei that synthesize ADH, the ADH axons coursing through the pituitary stalk, and the posterior pituitary where the neuron terminals secrete ADH into the circulation. It also involves deficient ADH release, which leads to diminished insertion of aquaporin II water channels into the luminal membrane of the collecting duct. This impairs the ability of the kidney to concentrate the urine, which leads to excretion of a large volume of hypotonic urine, increasing plasma osmolality, and stimulates thirst and polydipsia. For the pathophysiology of nephrogenic DI, it involves a disruption of the ADH-stimulated signaling cascade in the principal cells of the kidney collecting duct. The site of action of ADH at the levels of the kidneys is at the defective V2 receptor. V2 receptors are found in basolateral membranes of principal cells in the late distal tubule and whole length of collecting ducts. The G protein couples them to the cyclic adenosine monophosphate generation, which leads to insertion of aquaporin II water channels. Dysfunction occurs whether it is caused by mutations or medications, and it can cause insufficient generation of G protein stimulated cyclic adenosine monophosphate to activate insertion of aquaporin II channels into the apical membrane, insufficient insertion of biologically active aquaporin II channels into the apical membrane despite elevated intracellular cyclic adenosine monophosphate levels, autophagy and dysfunction of aquaporin II water channels, or downregulation of aquaporin II water channel synthesis and protein abundance in the principal cells of the collecting ducts. This causes terminal distal convoluted tubule and collecting duct insensitivity to circulating ADH, resulting in ADH resistance and a decreased urinary concentrating ability. For the pathophysiology of psychogenic DI, it involves abnormally low osmotic thirst threshold with increased fluid intake causing suppression of ADH secretion, excretion of large amounts of dilute urine, and the risk for hyponatremia. For the pathophysiology of gestational DI, it involves degradation of ADH by enzyme cysteine aminopeptidase secreted by the fetus. For central DI, the most common acquired causes include neurosurgery, trauma, autoimmune neurohypophysis, malignancy such as primary or secondary brain tumors, infiltrative diseases such as Langerhans cell histiocytosis and sarcoidosis, vascular disorders such as subarachnoid hemorrhages or ischemic stroke, hypoxic encephalopathy, and idiopathic causes or unknown causes. You can also have infections such as acute bacterial meningitis, though it is rare. Genetic or congenital causes include familial arginine vasopressin deficiency caused by an autosomal dominant mutation, Wolfram syndrome characterized by DI, diabetes mellitus, optic atrophy, and deafness, with cognitive and psychiatric issues that can appear later in life. Protein convertase subtilisin kexin type 1, deficiency congenital hypopituitarism, and septo-optic dysplasia. Nephrogenic causes can also be linked with genetics, such as recessive familial X-linked trait. Other causes include renal disease, such as pyelonephritis or a defect in the renal tubules, chronic hypokalemia or hypercalcemia, and certain medications such as lithium, methicillin, amphotericin B, aminoglycosides, rifampin, foscarnet, and cisplatin. Psychogenic causes include primary polydipsia, drug-induced intracranial etiology, and dyspogenic DI. Other causes of DI include pregnancy-induced and gestational form of DI. For DI, the risk factors will also have an overlap with the etiology. For central DI, the risk factors include family history, brain surgery, major head trauma, medication, and primary or secondary tumors. For nephrogenic DI, the risk factors include genetics, specifically males with the X-linked mutation, medication and metabolic disorders such as hypokalemia and hypercalcemia. For gestational diabetes insipidus, the risk factors include twins. For psychogenic DI, the risk factors include psychiatric disorders, neurodevelopmental disorders, hypothalamic disease, alcohol abuse, and stress. For the clinical manifestations of DI, the subjective data includes they could be asymptomatic and they can have extreme thirst, polydipsia, nocturia, irritability, anxiety, diplopia, headache, constipation, nausea and vomiting, and weakness, lethargy, fatigue, and myalgias. For objective data, they can have changes in level of consciousness, hyperreflexia, hypotension, tachycardia, increased urine output greater than 50 milliliters per kilogram in 24 hours. They can be hyperthermic with a fever, poor skin turgor, and elevated serum sodium and osmolality. For laboratory studies, a 24-hour urine collection will show polyuria with an output greater than 50 milliliters per kilogram in 24 hours. The urine will be dilute and odorless with hypoosmolality, and you will want to evaluate the glucose and creatinine. The BMP will show hypernatremia, hypokalemia, and hypercalcemia. There will be an increased serum osmolality of greater than or equal to 295, a decreased urinary specific gravity and urinary osmolality with a low urine specific gravity less than 1.006, and a decreased urine osmolality less than 200. For diagnostic studies, you will want to obtain a CT or MRI with and without contrast to assess the brain, hypothalamus, and pituitary gland for tumors, bleeding, and swelling. You can obtain a chest CT to assess for sarcoidosis, and you can obtain a CT of the kidneys if an acute injury is suspected. You can also conduct a vasopressin challenge test, which involves administering desmopressin acetate intranasally or sub-Q or IV. The urine volume is measured 12 hours before and after administration, and sodium levels are checked for hyponatremia. For central DI, you will have a positive challenge test, which means thirst decreases as well as polyuria, and the sodium usually remains normal, while nephrogenic DI will be negative.
Now we have the pharmacological evidence-based practice of diabetes insipidus. So you can give normal saline followed by half NS to replace half of the free water deficit. Free water deficit can be calculated by 0.6 times the patient's weight in kilograms times 140 over the serum sodium level. You don't want to reduce the serum sodium by more than 10 to 15 MEQs in a day. You can also give desmopressin. You can give 1 to 4 mics every 12 to 24 hours, and then you'll need to replace fluids as necessary. The electrolytes and BUN should be monitored frequently in these patients. And desmopressin increases water reabsorption by the kidney, and it also has vasoconstrictive properties. You'll want to reduce aggravating factors such as corticosteroids, and then you can also give hydrochlorothiazide and a potassium supplement concurrently. The hydrochlorothiazide may be ordered for central or nephrogenic diabetes insipidus, and since there are side effects such as hypotension, weakness, and nausea, only 50 milligrams a day should be used. You can also use chloropropamide, and that's used to reduce thirst sensation in patients with continued hypernatremia. It also may cause hypoglycemia. And then in nephrogenic DI, you can give indomethacin, hydrochloride, 25 to 50 milligrams a day. And then you can also give indomethacin desmopressin. And then you can use amiloride in lithium-induced nephrogenic diabetes insipidus. This drug may cause hyperkalemia, so again, you want to monitor electrolytes. And then you also want to get regular measurements of lithium levels because the dose may need to be decreased because the medication can also cause lithium toxicity. Some non-pharmacological evidence-based practice for diabetes insipidus. So you want the patient to consume a diet low in sodium and protein, which means that you want them to reduce processed foods, you want them to reduce consumption of processed meats, and you want them to reduce consumption of nuts. And then you also want them to consume quite a bit of fluids. You want them to replace, their fluids, so they can drink up to 2.5 liters a day. Then we have our interprofessional collaboration. So in diabetes insipidus, you'll often see the endocrinologist involved because it does have to do with hyposecretion of ADH, which is a hormone. And then you'll also potentially see nephrology involved. And then you'll see pharmacy, nursing, and then often the dietitian is involved so that they can, come up with a diet plan with the patient that's low in protein and low in sodium because that's often difficult to manage outside of the hospital. And then lastly, we have geriatric considerations. So it's important to note that the elderly have several comorbidities, which can complicate a diabetes insipidus diagnosis. It can create a longer list of differentials, more tests that you have to go through, a more comprehensive exam. And then the desmopressin dose may have to be decreased because of the renal decline in the elderly. As mentioned before, the renal mass, GFR, all those things can occur, so the dose may have to be less. And then the elderly patient may be susceptible to dehydration, so it's important to monitor their fluid status. Dehydration may present one way, in young adults, and then it may present a completely different way in the elderly.
For question number 1, which of the following does not meet the criteria for a diagnosis of SIADH? A. Serum sodium less than 135. B. Serum osmolality less than 275. C. Urine osmolality less than 100. Or D. Urine sodium greater than 40.
Okay, so the answer is C. And the rationale behind that is the Schwarzenbarger clinical criterion, which includes serum sodium less than 135, serum osmolality less than 275, urine sodium greater than 40, urine osmolality greater than 100, the absence of clinical evidence of volume depletion, the absence of other causes of hyponatremia, including adrenal insufficiency, hypothyroidism, cardiac failure, pituitary insufficiency, renal disease, hepatic disease, drugs that impair renal water excretion, and correction of hyponatremia by fluid restriction.
For question number 2, which of the following is not a common cause of SIADH? A. Traumatic brain injury. B. COPD. C. Brain tumors. Or D. Addison's disease. The answer is D, and that is because common causes of SIADH include, but are not limited to, CNS disorders, malignancies, pharmacological agents, chronic lung disease, genetics, and HIV. COPD, traumatic brain injury, and brain tumors can all cause SIADH. Addison's disease or adrenal insufficiency should be excluded before diagnosing an individual with SIADH.
So now we're on question 3. Question 3 says, a 25-year-old male who just underwent pituitary surgery is brought to the hospital complaining of muscle cramps and weight gain. After obtaining labs, his serum sodium concentration is 120 MEQs per liter, and his urine osmolality is found to be 350. What is the likely diagnosis in this patient? A. SIADH, B. Diabetes insipidus, C. Glioblastoma, or D. Type 2 diabetes. So if you said answer A, you were correct. The answer is A, SIADH, and the rationale is that the patient has a serum sodium of 120 and a urine osmolality of 350 and he's symptomatic. He has weight gain and muscle cramps.
For question 4, a 28-year-old female presents to the clinic with complaints of excessive thirst and urination for the past 6 months. She reports drinking around 6 liters of water daily and producing large amounts of urine. Physical examination reveals dry mucous membranes. Her labs show a serum sodium level of 147, serum osmolality of 300, and urine osmolality of 180. A DD-AVP challenge test is ordered, and after administration of desmopressin, the patient's urine osmolality rises from 180 to 198, with no significant improvement in symptoms. Based on these findings, which of the following is the most likely diagnosis? A. Primary polydipsia. B. Nephrogenic diabetes insipidus. C. Central diabetes insipidus. Or D. Diabetes mellitus. The answer is B, because an individual with nephrogenic DI will have a negative DD-AVP challenge test. For this patient, her urine osmolality remained less than 200 and did not have an improvement in her symptoms after the administration of DD-AVP. Therefore, she had a negative DD-AVP challenge test.
And lastly, we have question 5, which says a 35-year-old woman presents with excessive thirst and urination for the past 2 months. Lab tests reveal a low urine osmolality and high serum osmolality. A water deprivation test is performed, which shows a significant increase in urine osmolality after administration of desmopressin. What is the most likely diagnosis? A. Nephrogenic diabetes insipidus. B. Central diabetes insipidus. C. Primary polydipsia. Or D. Hypercalcemia-related polyuria. If you said B, central diabetes insipidus, you were correct. It's B because of the significant increase in urine osmolality after administering desmopressin, which suggests the kidneys are responsive to ADH, which is lacking due to a deficiency in its secretion from the posterior pituitary. So that would be central diabetes insipidus.